So, Rahul, as an up-and-coming investigator in the field, what caught your attention when you look at the SUCCESOR-2 data?
Yeah. So I think the biggest thing is that it's BCMA sparing, right? So two things actually I would say. One, phase 3 data, as you allude to, Katja. I mean, in the US, we have access to KPD, but it's often a struggle with insurance companies, and most of the world, KPD is not a regimen that anyone can prescribe. Hopefully, it's not a wooden chair, but I'll knock on it anyways. In the future, we'll have MeziKd as an option around the world. And most of these conferences, all we talk about is BCMA this, BCMA that. We're going to be talking about BCMA later today as well, but this is not BCMA. And I think the key part here is that I think for patients who maybe are considering BCMA CAR T therapy in the future, but need debulking, need something else beforehand, this is an excellent regimen for them. There will inevitably be patients where, you know, BCMA therapy, you try it doesn't work, they're non-responder, or relapse afterwards. This, in my mind, works equally well whether you are BCMA exposed versus not. If anything, the mezigdomide may actually offer some benefits in the post T-cell engager therapy option. So I think we need these options for our patients, right? Because a post-BCMA and even the pre-BCMA landscape is really wide open right now. And I think now we'll have phase 3 data supporting MeziKd for these patients. So
yeah, I completely agree. And I think the other thing that I wanted to share is that we had really striking data for PFS2, didn't we? The hazard ratio is 0.53. And interestingly enough, in the KD arm, there was twice as much bispecific use in that group of patients. And yet still, despite that, the PFS2 was strongly in favor of the Mezi arm. And I think as we think about survival, recognizing it remains immature, the good news is we don't see any kind of crossover, and I think that's really important. So it tells you about the tolerability that Katja, you so nicely framed, is very real, because that crossover of survival is not there. And so, Thanos, as you think about this, would you care to gaze into the crystal ball of survival for SUCCESOR-2?
Yeah, I think based on the very large difference in the PFS2 and the trend for survival advantage with a hazard ratio of 0.79, it is very probable that there will be a survival advantage as well. And as you said, the treatment that the patient randomized to the control arm that were given were, state-of-the-art therapies, bispecifics, IMiDs when the patients had not received them. And also, the other point is that we have to keep in mind that this is not two KD regimens with the same dose of carfilzomib that mezigdomide was added on. Actually, the carfilzomib dose in the mezigdomide arm was about 2/3 of the control arm. So speaking to the synergism and the potency that mezigdomide offered to the combination.
Yeah, that's an excellent point. And I think the other sort of critical point to share from a design point of view for the audience is that we had a 3-to-2 randomization because we were very conscious of the fact that that this combination was likely to be synergistic. So we tried to retain as much equipoise for our patients as possible, which I think is a critical point. So one thing to sort of help with contextualizing this for our audience is to think about cross-trial comparisons. Now, we have to be careful because there are all sorts of caveats, but let's face it, that's exactly what we do day in, day out in clinic. And in this context, as we had from questioners in the audience, do we compare this to Aspire? Well, absolutely not, right? Aspire was 15 years ago, lenalidomide naive and or sensitive, etc. No trace of CD38. So if we look at studies that are comparable, we would think basically about CELMoD-3, and we'd think about CARTITUDE-4. And if we look in the specific groups of patients who are CD38 exposed and or refractory, len exposed and or refractory, it's quite instructive actually, because I'm particularly struck that in CELMoD-3 with ide-cel, the PFS was 13 months, and that with CARTITUDE-4 it was 19 months. So again, the results from SUCCESOR-2 being 18 months, I think is encouraging, with all the caveats. But if I may, Thanos, say...